So in patients with placenta accreta, we should prior planning is needed, where we do the prophylactic procedure for decreasing the peripartum hemorrhage and as a part of uterine sparing surgery. So before going into the detailed description of the technique, first I will tell about the uterine blood supply. Normally the gravid uterus derives its blood supply from the uterine arteries, which are the branches of anterior division of the internal iliac artery. Along with that, it will also receive blood supply from the vaginal arteries, which are also branches of the internal iliac artery anterior divisions. And along with that, it can derive its blood supply from the median sacral artery, which arises from the aorta before its bifurcation. And sometimes the collaterals may arise from the lateral sacral and iliolumbar arteries, which are branches of posterior division of the internal iliac arteries. So before taking the patient to the OT, the patient will be shifted to the cath lab, where the prophylactic balloon occlusion catheters are placed within the internal iliac artery. And once we have placed, the patient will be again shifted to the operating theatre. And after delivery of the baby, we will inflate the balloons to prevent this postpartum hemorrhage. I will explain in detail later. These are the various techniques of prophylactic balloon occlusion. The balloon occlusion can be placed at the aorta level, that is just below the level of inferior mesenteric artery origin, or it can be placed within the internal iliac arteries, or within the uterine arteries also. So here we can see we have taken the bilateral common femoral arterial axis, and we have crossed over to the opposite sides, and we have placed the catheters within the internal iliac arteries. Here the balloons are also taken inside the internal iliac arteries, but they have not yet deployed. So this is how the patient is prepared before shifting to the operating theatre. Here we can see these are the markings with respect to the balloon. Once we inflate the balloon will be deployed across these markers. Here the femoral sheaths are sutured to the skin, and the balloon occlusion catheters are also tied to the patient's skin surface with an adhesive. Once the patient, and also during this placement of the balloon occlusion catheters, it is a fluoro-guided procedure. We should take, still the baby is inside, we should take adequate measures to decrease the radiation risk, such that we need to keep the eye away and the detector close to the patient body, and we should do intermittent fluoro. So once the baby is delivered, here we can see the balloon occlusion catheters are deployed within the internal iliac arteries. So these are the deployed balloon occlusion catheters in the internal iliac artery. But sometimes what happens is, because of the extensive uterine blood supply, even after the balloon occlusion catheters are deployed, there will be some sort of collateral flow and there will be ongoing hemorrhage. In such scenarios, there is no other option except for doing this uterine artery embolization. And in some scenarios, we have to go ahead with the extensive pelvic devascularization by carefully selecting the selective arteries which are bleeding. Here, after deployment of the catheter, still there is active hemorrhage. So here we can see the uterine blush coming from this uterine artery. Here, this is after embolization using gel foam, where the uterine artery branches and the blush is not at all seen. However, there are few untoward complications which can occur during this technique, because before delivery itself, we have placed this balloon occlusion catheters in these large vessels, so that because of prolonged stasis, there will be thrombotic complications also. Here we can see multiple filling defects across the external iliac artery. So for this, we need to do the some sort of aspiration thrombectomy to remove this thrombus and all. So coming to this, where in patients with the placenta accreta spectrum, where the severity is the percreta spectrum, where there is extensive extrauterine invasion, where there is extensive vascularization because of the collateral flow from the external iliac arteries, median sacral arteries, sometimes from the inferior mesenteric arteries also. So in such patients, we do resuscitative endovascular balloon occlusion of the abdominal aorta. Here we have seen this balloon is inflated in the infrarenal segment of the abdominal aorta. So technically it is quite simple compared to the crossover technique, because here we need to access a wire within the abdominal aorta and place a balloon over there. There is no need for crossing over to the opposite sides from both the femoral axis. Once we place the balloon here, we can't keep it continuously for 1 hour or 2 hours. It is advised to inflate with 20 cc of saline and keep the balloon for 15 minutes. And we can do multiple times with 5 minutes of delay. So coming to the complication part, the complications of the procedure itself, it can be from the 2 to 5%. As we go more proximally, the complication rate decreases because we will be able to address all the vessels supplying the pelvic vascularity. But as we go distally into the uterine arteries, the chances of complications are even higher because of we are reaching the end arteries and the chances of uterine necrosis is high. In such patients, the patients will eventually end up in hysterectomy. So some groin side complications will also occur, that is pseudoaneurysms and hematomas, sometimes arterial thrombosis and dissection also can occur.